some of the dumbest stuff that people say about TRT.
Welcome to this channel. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please subscribe and hit that notification bell.
The doctor told him, I'm going to take you off TRT and try jump-starting you on HCG and Clomid for a while, even though you've had a vasectomy, and then maybe put you on some herbs for a while because you're only 35 and you're still young.
Just let's make you feel worse just because we can, basically. Why are people so afraid of testosterone? The guy's done having kids. He needs testosterone replacement. What is this fascination with jump starting them and putting them through hell, literally putting them through hell just to see if it's going to work? And in most guys, it doesn't. It doesn't make sense. Especially if you're done having kids, if you need testosterone, you're going to feel better 99 times out of 100,000 on testosterone. Like, maybe there's an occasional guy that would have felt better on Clomid, and I think he probably just didn't need to be on testosterone in the first place. As I've seen those pop up every now and then, some guys like, I just feel better on Clomid. I'm like, that makes no sense physiologically. No sense. I mean, and the majority of guys you talk to on Clomid hate their life. It's miserable. But yeah, no, I don't understand why any doctor would do that. Or guys will be on testosterone and then they'll get referred to an endocrinologist because their doctor just really doesn't want to do the testosterone. Endocrinologist then goes, all right, we got to take you off your testosterone so we can get a new baseline.
Yeah, I was about to bring that up.
I heard it this week. A lovely patient that came to see me Friday he's in our group, came in from from Pennsylvania. And he went through all this crap. He went through all the horrible stuff before he finally just had to go with telemedicine and just kind of do things on his own. But he went through the treatment. He went through seeing an endocrinologist, told him, he walked away. He didn't do it. But his endocrinologist told him, okay, we got to take you off to get a new baseline. I'm like, your new baseline is you're zero.
Zero.
Suppressed. Like,
there is no baseline. You're suppressed. What do you... Doctors watching this, you're going to take people off their testosterone to get a baseline. Are you nuts? They don't have any testosterone. They haven't been making testosterone forever. What do you think you're going to find? Seriously. It's like, Jesus. And I see it all the time in the group.
You're going to find low T, low LH, low FSH. You're going to find exactly what you would think you'd find if you understand how this works. And the fact that so many endocrinologists, I don't understand their thinking here. I don't. It does not make sense physiologically. Ethically, to me, it doesn't make sense to do that to somebody.
Jordan, they're endocrinologists. These are supposed to be the guys that studied hormones. These are supposed to be the guys that are teaching you, or even guys like me that want to learn, that are the experts in hormones. And they don't realize that they won't have any testosterone if they're on TRT. But you're an endocrinologist. If you don't know, who's the expert I'm supposed to go see to find out about this? Because I thought it was the hormone doctors, the endos. No.
And that's the tragedy of it all. And I'm not blanketing every endocrinologist. There's plenty of endocrinologists that understand this stuff, I'm sure. But in general, from what we hear,
we've seen a lot of them.
Somebody says to us, I'm gonna go find an endocrinologist to help me with this. I tell them, don't.
Which is crazy, because that's the guy you would expect to send these people to. Go to the hormone expert.
With testosterone, for whatever reason, with sex hormones, I don't know. I didn't go to endocrinology fellowship, so I don't know if they're just not pushed on that side. I still think that, again, there's so much bias against testosterone. A lot of doctors are just like, these guys aren't really, yeah, we'll give them some, but it's not a real thing. Of course, their papers are coming out, even from their own journals, showing it treats obesity, treats diabetes. So at least there's headway from that side of it. But a lot of them are just still stuck in the past. That's why I think urologists should be at the forefront of this, honestly. We treat men, we treat male sexual dysfunction. We should be the leaders, but there's just as many urologists. There was a survey done at one of the annual meetings several years ago asking urologists how to better treat low sperm counts. And I think 25% of the guys in the room said to give them testosterone. you don't give testosterone to improve sperm counts. It's suppressive. So the fact that even 25% of these guys, and they're smart people, I mean, it's hard to get into urology residency, you know, but it just goes to show that you're just the hormone side of things. It's like this mystery world. And a lot of people, they don't pay attention. They don't think it's that important. They didn't really listen when they were talking about negative feedback. You know, I mean, I've known about this stuff since I was 17. But if you don't really care about it, you're just not going to listen and do it the right way. Endocrinologists are great with diabetes, sometimes with thyroid, adrenal issues probably. But sex hormones, they're just, as a whole, they're not quite sticking with the evidence. So, yeah.
This next one kind of goes is very similar to one I asked before because it's an AI one, but guy was asking, what AI would you recommend? Which one is the least toxic long term? If you know you shouldn't be blocking estrogen, then don't touch an AI. There's no point to take an AI to figure out which one is least toxic because you know you shouldn't be taking one because it's been demonstrated.
I mean, there's certain ones that are more powerful, but that doesn't matter. I mean, you're missing the forest for the trees here. The whole point is you don't need it.
Yeah.
They're all harmful if you're blocking estradiol. Now, obviously, if you're blocking it more, there's probably more harm done. If you're taking something like letrozole and literally have single-digit estradiol, that's probably more harmful than if you're taking Aromatase and your estradiols in the 40s. You know, I mean, but there's no need to take it. You just don't. And you're screwing up your body's ratio just by doing that.
Yeah. Another one quick, high estrogen causes hair loss. No, it doesn't. It doesn't. And if it does, send me the bloody evidence that it does, and I'll look at it because you can't, because it doesn't, and you won't be able to send me it.
People blame DHT for hair loss too. Like, is DHT a factor? If you're genetically prone, yes, but DHT alone does not cause hair loss. I don't understand.
But now you're going to get a guy in the comment when this video gets posted and say, yeah, but look at Danny Bossa. He lets his E2 run rampant. He lets his E2 get high. And he doesn't, no, guys, I got hair. I just shave it all down because my wife thinks it looks good. And she's the only one I got to make happy. But no, it doesn't. And if you think I'm full of shit, send me the evidence to put me in my place and say, yes, it does. Look at the study. It does. I'd love to see it. But yeah.
It's no different than E2 causes XYZ. I mean, there's just whatever.
Yep. 800 to 900 total T is plenty, and anything over that is a steroid cycle. We've talked about that earlier. It's absolutely ridiculous. Yep. You probably, there's a guy that you know very well, actually, and I'm not going to say the name, did not feel good with his testosterone, total T, I think it was under 2000. Did not feel good at all. And as soon as he got over 2000, suddenly he's like, man, I feel a hell of a lot better. So what are you going to do there? Are you going to say, no, it's too much? Why? What would happen for him staying here? What evidence do we have that him staying at this level is harming him? His health issues are gone. So what do we do?
Yeah. Because I know the guy you're talking about, and he is not a bodybuilder. He's not looking to abuse. He is a
older guy,
well-respected man, intelligent. He may be a physician. And he's just thankful he found someone to treat him, because most people never would have. I think he started in the 600s maybe, and he was symptomatic, and for whatever reason, he needs that free T to be higher to feel well. And that's the thing, is everybody's an individual. I don't like saying we're biochemically unique. I don't want to say that, because I don't want
you to say that either.
We're not that unique. I mean, our processes all pretty much run the same, otherwise we'd die. So that's not true. But on a certain spectrum, yes, everybody might have a different number that they need to feel better. And that can depend on their metabolism, on endocrine disrupting chemicals in their body. I mean, all this stuff. Like there are those external factors. You can't say I'm biochemically unique on the inside. No, our cells all pretty much work the same way. But there are factors that apply forces onto your mechanisms. And we don't know what they all are. We have no idea. I mean, there's all kinds of DNA methylation issues, and like I say, endocrine disruptors and androgen resistance. you got to go with how somebody feels. I mean, is it rare for a guy to need to be over 2,000 to feel optimized? Yes, it is rare. Is it a problem long term? Why would it be? I mean, do you really think there's that big of a difference from a health standpoint with somebody who's at 1,600 and somebody who's at 2,000?
Yeah.
I mean,
but then you got the guys that'll say, yeah, but we don't have any long-term studies.
I know.
Okay, but do we have anything that indicates that it's harmful? No, we have it. So if in the interim his health issues are gone, is that not already something demonstrably good? And if there is harm, let's say there is harm that we're not going to know about, it's not just going to hit them all at once. It's not going to wake up tomorrow and there's a whole ton of issues, right? This might be a gradual change that might take over time. And if he's having regular bloods done, his doctor at one point might say, I'm noticing with every blood lab, this value continues to creep up. Maybe it has to do with this higher dose. Maybe we should consider bringing it down a little bit and see if, if it comes back down. But this isn't something like, oh my God, I was on this level and now the next day, I've got all these issues and I wish.
There's no acute overdosing on testosterone.
Right.
Guys take grams upon grams a week and can stay fine, honestly. I mean, a lot of guys can. So we're talking about pretty small doses compared to what, it's all relative, because I mean, in the bodybuilding world and things that I've been around, you can have blood levels of 10,000 on your testosterone. A lot of these guys do. I mean, it's crazy.
Mm-hmm.
So when I see 2,000 or 1,800, I'm like, okay. I mean, so it is all relative. But there's a lot of doctors, if they see 700, they freak out. So, but you got to take the person as an individual. You got to go off symptoms. Again, what if he kept having to go up and up and up and up and he's at 3,000 and he's not feeling any different? It's like, okay, like there is a point where you go, I don't think testosterone is probably your issue, Yeah. That doesn't mean it's not. It might be. You might be a weird outlier. There's always what we call the zebras in medicine. Don't go looking for them, but they're out there. The weird things. We just need more research.
I couldn't even handle 2,000 or 3,000 if I tried.
Yeah.
I was telling Jordan offline that I had skipped a couple of doses, so I gave myself a 200 milligram injection all at once, and I didn't sleep for 3 days. So I can't. The more is better doesn't work for me at all, but for some guys it does. It is what it is. Doctor looked at the guy and says, you probably don't need TRT because you have a beard, and you can't grow a beard if you've got low testosterone.
I don't even know what to say about that.
I don't even know what to say about that either. It's dumb. It's dumb. Just again, I heard someone knocking at the door just now. Hold on a second. Angie? Yeah? There's somebody knocking at the door. Okay. Jordan, talk. I'll be right back. Hold on. Seriously.
Yeah. Oh, man. What am I going to talk about? So, I'm going to talk to the camera by myself, guys. Now, hair growth patterns are usually established early on. So, if somebody was low T when they were young, going through puberty, I was just saying hair growth patterns are established when you're younger, when you probably had normal hormones. Like, yes, if you didn't go through puberty normally, it would be an issue.
It's okay.
You can't look at somebody's hair patterns when they're adults and tell if they're low T or not. You just can't. Or feeling their testicle size like you had done. Like, it's just not.
Right.
It's voodoo. So. Yeah.
With me, it was a female endocrinologist.
Yep.
She was the top endocrinologist in Montreal where I live. And she had me lie down on the table and I pulled my pants down and she's just going like this. For probably what felt like 30 seconds. And she says, they're a very good size. You're fine. You're fine. And I'm like, no, they're a good size because I'm Italian. It doesn't mean I'm fine. I'm not fine. She says, no, they're fine. You've had children? Do you have children? Yeah, I have 2 kids. You're fine. You're fine.
Yeah. Guys with low T can't have kids. Yeah, absolutely. Yeah. It really blows me away, man. It really does. And I know we get on these soapboxes, and I talk like this every day in it too, so it just bothers me. Yeah. So that's why we're here to help.
Over here. TRT will cause roid rage. No, it doesn't. It doesn't cause roid. Oh, wait, sorry.
Oh.
Yeah, no, it doesn't cause roid rage at all. Just kidding. No, guys. Again, if you're a dick and you get on TRT, you might become a bigger dick. And frankly, like I said, I'm in my own experience, and this is anecdotal, I find myself less likely to blow up or less likely to react to things around me that I found myself reacted to way more. A huge example is, what's it called? Road rage. When you're driving and someone cuts you off, like I'd be like on that guy like you wouldn't believe, and now I'm like, whatever, idiot. You just have that a little bit more of that calmness side. So,
and I'll say this: a lot of the guys that have these issues are blocking their estradiol. When you're on aromatase inhibitor, because I've been there, done it, we see it all the time. You are much more hair trigger. Your mood is much more labile. Women who have low E2 complain of the same thing. It's postmenopausal women. There is a big factor of the estrogen in there, and estradiol is actually a feel-good hormone. Serotonin, it enhances serotonin and all that stuff. So if you're blocking your E2 and you're being an a-hole, it's not because you need to block it more. You may just need to stop your aromatase inhibitor. I promise.
There you go. Yeah. So hopefully your wife or girlfriend is watching this video with you, and she's going to turn like, I think it's time you stop your AI. Right. And then you're going to be like, shit. And then you're going to do it, and then you're going to feel better, and then you're going to write in and join the group and say, oh my God, you guys were right.
Join our cult.
Because our cult, our high E2 cult.
We are nuts.
You guys are all nuts.
Shills of big E2.
Yeah, because we just want to come on and just talk about something that is demonstrably false, just to waste our time, just for fun, because we're that dumb.
Yeah, just to stir up controversy and have people hate us. We love that. I love it.
We haven't looked into this at all. Yeah. Boy, oh boy. TRT.
I think this is a good one.
Oh, yeah. This was a couple days ago in our Facebook group. A guy said to have high free T, it means you're letting your DHT levels go up. And after a few years, you'll need a catheter to piss. You're a urologist.
Yeah, this hits close to home here. And we've talked about this before, so we don't have to belabor it. There are great studies done now showing that the serum T levels don't affect the intraprostatic DHT levels. Prostate, goes back to endocrinology, endocrine processes. Same thing with E2. DHT is made in the cells in different amounts, and it's finely regulated. And in fact, they've even done studies on men with prostate enlargement and without, measured the DHT levels. They don't find a difference. It's not DHT that's causing prostate enlargement. The prostate is an androgen-dependent organ, yes. If you withdraw androgen from the prostate, it will shrink it a little bit. If you give it more, it does not necessarily grow it more. So it doesn't work both directions.
So if it does grow a little bit from someone who's been on a protocol, that they see their PSA levels go up, or maybe they feel that there's some, what is that cause?
A lot of times when I see these guys saying they're getting swollen prostate from TRT, they're not. It's not necessarily growing their prostate. They're getting pelvic floor dysfunction. A lot of it's from anxiety. And they'll get these tight perineal muscles, the levator muscles that surround, it's like a hammock that the prostate sits in. And when they're tight, they give guys urinary tract symptoms. I see it all the time. And high stress guys, and they have anxiety, and you do a rectal exam, and their muscles are tender in there, like literally, not like they're tender. They need pelvic floor physical therapy. They need the anxiety techniques and all that stuff. A lot of times Cialis helps. I think it helps the blood flow down there, daily Cialis. I'm a big fan of that for pelvic floor dysfunction. And there's a guy in our group that can attest to this. He was told his prostate, he thought he was going to get prostate cancer, and turns out he had pelvic floor dysfunction after he'd started his testosterone, or it may have just been coincidence with his testosterone. He was just anxious. But technically, the serum levels of testosterone and free T do not affect the prostate levels of DHT. We have studies showing that. So it's myth. It's, people used to say that. They still do all the time. Oh, you take testosterone, it's going to blow up your prostate. No, the prostate's going to grow if it's going to grow. If you're genetically determined to have a big prostate, just like if you're genetically determined to lose your hair. Otherwise, you're good. So.
Yeah. Or testosterone will make your penis shrink is the next one.
Yeah, I used to hear that all the time growing up, because they'd say steroid users, they have small penises.
Yeah. They're going to wind up with small testicles and small penises.
Small testicles, smaller testicles, sure.
Yeah, sure.
Not
Yeah.
small. Yeah. Doesn't
Yeah.
affect, doesn't affect the penis size.
Yeah.
It may actually make it look bigger because your testicles are.
It may actually make it look bigger because it will get bigger from the better erections that you had before. It won't make it look smaller. That's for sure.
I need to address something that was a dumb thing. This was months ago that I don't know that we ever talked about. There was a doctor that posted a link to this saying a urologist said it. And if a urologist said it,
it must be true.
They said that you need to take HCG to keep your testicles larger because that's what helps prevent you from losing an erection. It helps to prevent venous leak from the penis, your testicle size.
Oh yeah, I remember you told me about this one.
This is just, I told my wife this. I mean, we're both urologists. It's literally one of the dumbest things I've ever seen. And the fact that this anabolic doc said that a urologist told him this, I don't believe it. I don't believe any urologist would say this. Anybody who knows anatomy, and I told guys, I was in a different group, and right before I think I got kicked out of that group, I said, I want you to do an experiment. When you have an erection, I want you to go feel of your testicles and tell me if they're compressing your penis to keep the blood from flowing out. Everyone can do this. It's not hard. And the answer is no. The testicles are not helping venous compression from losing an erection. It was the dumbest thing I'd seen in a long time. So I just had to throw that out there. If guys ever see that posted, this is a popular testosterone doctor that posted this. And it's just not true. So
there's a lot of doctors posting stuff that is
yeah, and that's what, and again, like I always tell people, don't believe everything I say because I'm a doctor. You need to go look it up. But anyone can go look at the way an erection works. You can read a urology textbook and look at the way the veins are compressed. When you have an erection, that's what compresses the veins circumferentially. If the testicles are just pushing on one part, you can still have venous leak. Even if that were true, you can still have venous leak elsewhere. Testicles do not help in maintaining an erection mechanically. It just doesn't work that way.
Yeah. Anyway. Yep. Guys, if any of you watching this video or any other video we do, and there's a part of it that you don't believe or part of it you're not sure of, send us a message. You can join the Facebook group, TRT and Hormone Optimization. Anyone's free to join, and you can say, hey, I saw such and such video, and you guys were talking about that. I want more information because either I don't believe it or the evidence I have it goes against what you're saying, or I want to know more. And we're going to provide you with as much literature that, I mean, we didn't write the literature. It's the medical literature. It's there. We'll provide you with the studies and everything to support what we're saying. You can provide what you have to support what you are saying, by all means. Okay. But there are guys on different channels who often make insults about me or my channel or some of the guests I have on who provide nothing. Again, the anabolic doc who talked about this venous leak doesn't really provide anything that I saw that was backed up anything he was saying. We got the other Dr. Stevens over in the UK, who every second video is about estrogen, and why it's bad and why you need to control it and has to be managed or whatever, has not once provided a single paper or a single little sliver of evidence to support anything he's saying. But he'll sit in his car day after day in the parking lot of his empty clinic talking about these things over and over and over and over and over. I don't see any research. I don't see any papers. I see nothing. We will provide research. Jordan Grant, and just in regards to YouTube, provided a huge Google Drive full of stuff. Some people pointing out some of the stuff is inaccurate. By all means, again, show me what you've got that says that this is wrong. So we are open to having our minds changed, but you need to come in with something that can demonstrate what you're saying is true. So don't just listen to guys sitting in their cars or talking about whatever else, saying this is this and this and this and this and this with no information. Everything I say, I can provide information. Everything Jordan says, can you provide information? Or Jeffrey or any other people we've had on, you ask them a question, they will provide you. They will drown you in literature if need be until you say, okay, I got it. I agree with it. Okay. So keep that in mind. Use some critical thinking and just don't believe everything you see online.
Yeah, and there are things that we don't know yet. I mean, there's papers. You can find papers to support any position you have. But if you dive into the papers, you realize a lot of them are irrelevant. So that's what I've seen. A lot of guys will bring up a paper where they were looking at E2 levels in a man not on testosterone, or E2 levels in a zebra finch, and all this, like, it's just, or they're given cell cultures and they're adding these hormones and then seeing what the cells do. That's not what we're talking about. I mean, yeah, those things can be useful and interesting, but you have to actually look at studies that are done on humans, that are done in a way that makes sense. But there are stuff that we don't know. There are things we don't know. The hematocrit thing, like, I'm still not convinced one way or the other on that. I think evidence is leaning to higher hematocrit from TRT not being a major deal. I think that's where, and there was a recent paper done just recently questioning that, saying we got to start looking at that. And at least people are asking the question, but there's no studies done on humans on TRT, and is their blood thicker? I mean, we don't know. And so
my guess is it's not a factor probably for most people that are in half decent health. It's the ones that are not in good health.
Yeah, there's other factors.
Something you want to monitor. Yeah.
But it'd be nice to know that for sure. There's never any certainty with this stuff, but it would be nice to have multiple papers. And like I said, there's a couple of good rodent studies with TRT, with testosterone, looking at their blood viscosity parameters, and they're fascinating if people would take the time. Again, you can't always equate those to humans, but at least it's going in the right direction.
A lot of this stuff too is, go ahead, sorry.
I was just saying, question what we say, try to find, good papers and read the research. But the stuff that we don't know about, we'll say it. I'll say it all the time. I mean, guys are posting stuff all the time every day. Hey, what do you think about this? I'm like, I don't know. Or I've read papers on it and I go, I still don't know. I'm still not convinced one way or the other, and that's okay. We're not here to be, I don't know it all. You don't know it all. None of us know it all. We're just trying to find the most comprehensive amount of information on things that we kind of feel fairly certain about. And I think the estradiol papers are pretty overwhelming, to be honest with you. Just like all the TRT research is pretty overwhelming now that it's protective, cardioprotective, all this stuff. So anyway.
Hey guys, when I say do research, I don't mean like, oh, let me go in T Nation or Excel Mail or whatever else, and let me go post and see and get some feedback. No, that's not research. Okay, it's not. Go get actual research. I got two left over here. Doctor said, by law, I have to prescribe you an AI with your prescription.
I'd like to see the law.
I'd like to see the law too. If your doctors are telling you that, guys, ask him. I'd like to see the law. Can you please tell me what law it is so I can look it up? Amazing. Okay? And make him look stupid.
Such a cop-out.
Yeah. Just like when my endo told me 400 milligrams once a month. And I asked him, what's the half-life of anything? And he's like, I know the half-life. I said, so what is it? He goes, I know the half-life. I know what it is. I said, what is it? He goes, you questioning me? I'm an endo. I know what the half-life is. Said, so what is it? He couldn't answer the question. I couldn't do it. So, yeah.
I hear people say they can't by law let people do injections at home. They have to come to the clinic to do it.
Yeah. Huh? No.
Yeah.
Injection. A couple times a week. No cops are showing up. It's all fine, guys. So use your heads and think. And if something doesn't make sense, ask a question. Ask the question politely and say, can you demonstrate what you're saying?
Yeah.
That's it. I don't believe what you're saying. Can you demonstrate it? Yes. The other huge way we demonstrate stuff is, and sometimes it's hard to demonstrate to others, is just some of the stuff we see in our Facebook group. The number of guys that just come in, oh, I'm feeling off. And you look at their labs and you look at the thing. Oh, try splitting up your dose. You're taking it once a week. Just try 3 times a week and drop the AI. But keep your dose, you know what? Up your dose a little bit because your free T is only, 20. You might use a little more. And then like a couple months later, they come in like, oh my God, I feel so much better. Oh my God, I feel so much better. And oh my God, I feel so much better that you're just seeing over and over and over and over and over as every passing month, over and over and over and over and over. You're like, okay, well, this works. These strategies work. I mean, we see it. I mean, how many times have we seen it at this point? Thousands? How many, but then when somebody says, well, I don't believe it, sometimes it's like, yeah, but I don't know if you've seen how many times I've done this and the outcome is good. Go in the group and go read through every single post and you're going to see how many people have eventually chimed in to say, okay, that fixed things. Yeah. And if it didn't fix things, we would not be here telling you that it did because we would look stupid. And neither of us wants to look stupid.
And I don't promise people that it's going to fix all their problems. I don't always, I can go with experience and with research, especially with the estrogen thing, that every guy that I've dealt with to get them off their AI, they feel better. I know there's guys that have posted they've tried without it. I don't think they usually give it long enough. I tried 2 weeks without my AI and I just couldn't take it. You didn't give it a chance. Just like these guys protocol hopping every 6 weeks, they change their protocol. You're never going to get that in that way. You have to be patient and you have to kind of trust a little bit. As long as you're on a fairly decent protocol, meaning it makes sense physiologically, you're going to probably feel better. If you're on even 150 milligrams to 200 milligrams a week, split up over multiple injections, you're probably going to notice benefits after 2 months. May not be where you want to be, but you're probably going to feel better if you just.
It'll be a hell of a lot better.
Yeah.
And that's it. Speaking of which, the last one, doc told him, your estradiol is 80. That can only happen by heavy abuse of UGL steroids. We have to stop your treatment.
That's amazing. Yeah.
Your E2 is too high. We got to stop. So we got to stop your treatment.
So what you see, and we'll talk again, testosterone aromatizes to E2. Most of the other underground steroids that people take do not aromatize. So number one, taking high doses of steroids usually leads to lower E2. Those other steroids actually act as aromatase inhibitors, believe it or not. DECA acts as an aromatase inhibitor. Yes, it's true. Any androgen that can attach to aromatase can inhibit aromatase. If it cannot be aromatized itself, but it still binds, that's an AI. That's what AIs do. That's what steroidal AIs do. Testosterone in higher and higher doses, E2 flattens. So no, you can see in the graph on that paper when guys had up to serum levels of 3,000 or 4,000, E2 starts plateauing off and like low 100. You don't see guys with E2s of 200, 300, 400. You just don't. The only time you would really see that in a man, an E2 of like something like a female level of E2 would probably be if they have like an HCG secreting tumor, because there are those things. And that's telling the testicles to literally pump out estrogen. And that you can see those crazy levels, but that's very rare. And that's an issue because they have a cancer, that's HCG. But that's a whole other topic. We can talk about HCG is powerful stuff, and guys need to be careful with that because they might have estrogen symptoms if they're taking too much, because again, your body's literally making estradiol and pumping and flooding the system in pulses.
Throwing off the ratio.
Exactly. So that's different from aromatizing, which happens in the cells. So anyway,
but now there's going to be guys that are going to say, "Oh wait, nandrolone acts as an AI. Okay, so I can manage my E2." See, he said not to take an Arimidex or Aromatase, and so maybe what I can do is take nandrolone, and that will control my E2 without taking. So now I don't have to take an AI. I can take the nandrolone. No, you don't do that. It's just
in fact, these guys that want to be on nandrolone for their joint pain, which I get, even at low doses, they actually may need to increase their testosterone dose just a little bit to make up for that lack of aromatization. And nandrolone does convert to dihydronandrolone, which is a weaker form, and so it's not DHT. That's not good. We do need DHT. So anyway, you might want to actually bump up your testosterone just a hair to compensate for the nandrolone. So people think I'm crazy when I say that. They're like, "Oh, I take lower testosterone because I'm taking nandrolone." No, you need to match it or get more. I mean, physiologically at least, to stay healthy. I don't know about how you feel because you're taking a steroid that can make you feel weird. Nandrolone acts like a progestin. You can feel weird with it. And so that's a whole different topic. But health-wise,
I definitely felt weird on it.
Yeah, so anyway.
Just the small dose I did for my little YouTube video, my Danny Boss's nandrolone results, which I just took a tiny little dose to try it out. I felt weird after a while. Joints felt great.
Yep.
Joints felt wonderful, but up here and after a few weeks, not so much.
Yeah, it makes sense. Like I say, we need DHT. And then so when you got nandrolone converting to DHN is not DHT. Regardless of what some people say, it's not just the receptor needing to be occupied. It needs to be occupied by the right substance. If it just needed to be occupied, then testosterone's all you need, or nandrolone's all you need. It doesn't work like that.
No.
So that's a whole different topic anyway.
Yeah, if it was just like an on-off switch, is like what you're saying. It's
not,
either activated or not.
it's not.
Yeah,
It's
it's not.
very complicated. And I'm not an expert on androgen receptors. I've just, from the research I've done on it, it's fascinating that it's not just a lock and key type thing like we always think about. So anything else, any other crazy stuff that to finish on? I can't think of anything this week that was just, I don't know.
This is the, go ahead.
There was he's a YouTuber and apparently is opening up some TRT clinics. He's not a doctor, and literally told people that if you're not taking HCG with testosterone, you're not on TRT. I mean, guys are buying. No. Yeah, and in fact, he's pushing small doses of like 50 milligrams a week of testosterone and make up the rest with HCG. Yeah. So, yeah, we're not on HCG replacement. We're on testosterone replacement. HCG is going to cause more issues than it helps. And if you're trying to get high enough levels with HCG, you're probably going to have a lot of side effects. Just take testosterone. It's safe. We've talked about this. It's what your body needs. It's what your body knows. You don't need to be taking an LH mimicker like HCG. HCG is not LH. Okay, guys? It's not LH. It's not the same thing. I posted a paper on that discusses how they are not the same molecule. So anyway, I just thought that was interesting that he's kind of pushed, he's pushing that European guy's protocol of small dose testosterone with HCG to make up the difference.
With an AI also?
He didn't mention AI in there. I haven't seen any posts on that though. But yeah, it wouldn't surprise me because he's very much the bodybuilder. I think he's a former bodybuilder. He's obviously in that world, but and not everything the guy says is crazy. He'll say stuff about diet and exercise I totally agree with. So I don't blanket people like, oh, all bad, all good. But when it comes to this stuff, I mean, if you're a bro, you're great with nutrition and exercise, that doesn't make you an expert on hormones. And just because you're footing the money for hormone clinics, which is probably what you're doing, that doesn't make you an expert on this stuff. And then when you post stuff like that, and there's guys responding on there like, oh, this is amazing. Oh, I can't wait to get started. And like, God, they're going to eventually find their way to our group and we're going to have to tell them why they don't feel well.
Then you have to have them unlearn everything they learned and then say, this is why you don't do that for these reasons, and explain and explain and explain. And then after.
And that's why I tell guys, I like to get you dialed in on testosterone only at first. Even if you're going to add HCG for fertility, let's wait 2 months. You're not going to miss up anything waiting a couple months to add HCG. Let's find out what testosterone does to you, how you feel on it, where you feel best. Then when we add HCG later, if you start getting weird side effects, it's probably the HCG, and we need to figure that out,
Yeah.
Just one last thing. Like I saw it, I'm not going to say his name because he's a patient, but great guy last week, 27 years old, post-finasteride syndrome, which we probably need to do a video on this because it's a big deal. He took Propecia for a couple months. It wrecked him, libido, erections, depression, everything. Came off the Propecia, still has the symptoms, post-finasteride syndrome. And anyway, it just, I don't know where I was going with this or what the actual topic was. I had a point here.
I blanked out earlier like crazy.
I had a point because we were just talking about the HCG, and all this stuff. He's young. He's still concerned about fertility. Sorry. We've been talking about so much. But for him, like nobody are helping these guys. And there's no good research on whether hormone replacement's needed. His T level's pretty crappy for his age, like in the 300s. His DHT serum level is really low. Not that that's a marker of everything going on, but it might be an indicator. Pregnenolone was off, all this stuff just that didn't add up, and he still wants to maintain fertility. And I told him, like, let's try testosterone because that may be all you need to feel better. I mean, it's better than going antidepressants. It's better than going to just therapy, which is what a lot of places recommend for these guys. Like, you just need psychosexual counseling. That's not going to help you get your sensitivity back on your penis. But even in his case, I said, let's at least wait on the HCG for a couple months before we add that because we really need to figure out, in your case especially, how are you going to feel on testosterone, But I recommend that for most guys with HCG. So that's just something that I think is good to know for a lot of people. You don't have to jump on HCG right away. You don't have to be on HCG period if you don't want to maintain fertility. It's not a necessary component of TRT. It does have
Absolutely.
benefits in some people. I'm not denying that, but just be,
Some
one
people.
variable at a time.
Gil did a pretty good video on HCG, and I actually learned stuff from that video that I didn't previously know about HCG. So go check out that video if you guys are into HCG at all, about how it pretty much does nothing for FSH, right? Which was half of the equation. So check it out. It was just posted a couple days ago, maybe a week ago.
Yeah,
It was a very, very good video.
It did very, very good video. And that's why you see sperm counts will still decline even when you're taking HCG with testosterone, because you don't have the FSH doing what it needs to do. But it's okay, because let's say your sperm count goes from 100 million to 22 million. Well, you can still get somebody pregnant with 22 million, so that's the goal, but it's not optimal by any means. And there are other factors at play with HCG. Like I say, it can do some strange things in people. It's not a bioidentical hormone. It's not a receptor that's meant to be constantly activated.
Mm-hmm.
So there's just a lot of things people need to think about with that.
Yeah. So if your doctors are prescribing you testosterone and HCG and an AI and all this other stuff, ask yourself if you really need all that stuff, or if there's a chance maybe that the doctor just kind of makes money off all these things, or maybe doesn't know better. And we're telling you could probably do, or almost always do fine just with one of those things. Keep it simple. Get your protocol dialed in just with T, and that's it. That's it. And if it's for fertility, there's other things you can address, but you don't need all this crap, right? The next time you lucky fellas are going to get to see that beautiful man on our channel is pretty soon. It's not that beautiful. I'm just saying it because he's my guest. No, I'm just kidding. Next time you're going to see him on, we're going to do an Ask Us Anything. Me, Jordan, and Steven. Of the three of us, we'll do an Ask Us Anything live YouTube thing. And you guys can just hop on the YouTube channel and ask questions. And we'll do the best to answer them. So you can send me questions, Steven a question, Jordan a question, and we'll answer whatever questions you send, which should be pretty cool. So we're going to try to get that scheduled in the next, week or two or whatever.
And if we don't know the answer, we'll say,
I don't know. I don't know.
Yeah.
I don't know. Yeah. Sometimes I don't know is the best answer.
Often it is.
Yep.
I don't know, but I will look into it.
I'll look into it. I'll get back to you.
Right.
So guys, this was a pretty long video, but I thought it was pretty interesting, pretty cool. If you liked it, like it. If you didn't like it, dislike it. Doesn't change anything for me. Click the subscribe button. Click the subscribe button. I've been talking so long, my tongue is going numb. See, I still can't do it. Click the subscribe button. Did it. And the notification bell, so that when we have videos like this that come out, you'll be the first one to see it, and then you can go tell your friends and so on and so forth.
That's right.
That's it for today, Jordan. Thank you very much.
Sir. Very good time.
Pleasure. All right.